Welcome to the deep dive. Today we are tackling, well, a massive unit. It's one of the most operationally intense areas of clinical care, the entire surgical journey. You asked us to deep dive into Unit 3 from Brunner and Sutterth's textbook of medical surgical nursing, and our mission is to cut through the density.
Right, there's a lot there.
We are distilling the core concepts of perioperative nursing management into a high-yield, comprehensive guide covering all three critical phases: preoperative, intraoperative, and postoperative.
And this isn't just about passing a test.
No, not at all. It's about building the foundational blueprint for safe, successful patient outcomes in what is probably the most demanding setting there is.
That's exactly right. This entire unit, it's predicated on one single overriding principle: patient safety.
Patient safety.
We're going to use the text-detailed framework to really analyze the distinct phases. We'll be focusing on the specific roles, the complex physiological risks inherent in surgery.
Not many interventions.
And the non-negotiable evidence-based interventions that span that entire care continuum, from the initial decision to operate until the patient is completely and safely recovered at home.
Okay, so let's start with the structure of this journey. When we talk about the perioperative phase, we're really defining three distinct but interconnected boxes of nursing care.
Precisely. It's a sequence of flow. The first is the preoperative phase.
The planning stage.
Exactly. It's the planning and risk mitigation stage. It starts when the decision for surgery is first made, and it ends the moment the patient is moved on to the operating room, or OR, bed. This is where assessment prevents crisis.
Then we enter the OR, the real high-stakes environment.
That is the intraoperative phase. It kicks off upon transfer to the OR bed and runs until the patient leaves that environment and is admitted to the Postanesthesia Care Unit, the PACU.
Okay, and then finally,
the postoperative phase. That begins with that PACU admission, and it extends all the way through to the final follow-up evaluation, which could be days, weeks, or even months later.
and the unifying element, the theme that ties all three phases together, has to be maintaining a really robust culture of safety.
Right.
And the text emphasizes this by integrating the quality and safety education for nurses, or QSEN competencies.
In vital context. I mean, for anyone entering practice, QSEN provides the necessary framework for modern nursing. It requires specific knowledge, skills, and attitudes, the KSAs for safe care.
And we're talking about 6 core competencies.
6 of them: patient-centered care, interdisciplinary teamwork, evidence-based practice, quality improvement, safety itself, and informatics.
The definition of safety here is key, isn't it? It goes beyond just individual mistakes.
Oh, absolutely.
Yeah.
It's defined as minimizing the risk of harm to both patients and providers through system effectiveness and individual performance.
So it's a systemic approach.
It has to be. And that's best demonstrated through things like the World Health Organization's surgical safety checklist.
Which is rigorously enforced by groups like the Joint Commission.
Exactly. Let's think about that textbook example. The 82-year-old woman scheduled for a laparoscopic cholecystectomy. Her safety, it literally begins with this checklist.
And she is relying entirely on that system on compliance to protect her. So walk us through those critical pre-induction steps, the sign-in part of the checklist that has to happen before any anesthetic is given.
This is the moment where collaboration saves lives. The entire team, anesthesia, surgery, nursing, they all pause.
A full stop?
A full stop. They confirm the patient's identity, they confirm the specific procedure, verify that informed consent has been finalized, and critically confirm that the incision site has been properly marked by the physician.
It sounds so procedural, but every single detail matters. What about the patient's actual status in the equipment?
Absolutely crucial. They confirm the anesthesia machine medication check is done, and they make sure the pulse oximeter is on the patient and functioning correctly.
And then the screening gets really specific.
It does. Are there known allergies? Is there an anticipated difficult airway or aspiration risk that might complicate intubation? And, a big one, do we anticipate a high risk of blood loss, specifically more than 500 ml?
And if the answer is yes,
Then blood products must be in the room, ready to go.
so the nurse's role here isn't just, checking a box. It's actively making sure all these answers line up with the patient's chart. This ties right back to those specific safety KSAs the text outlines.
It really does. The knowledge component is knowing the organization's error reporting systems and how to foster open communication. The skill is the ability to actually speak up.
To stop the line.
Yes, to communicate observations or concerns about hazards or errors to the whole team, even if it means halting the process for a moment.
And the attitude. Which is probably the hardest part to teach.
I think so. It's valuing the systemic approach. It's believing that national campaigns and checklists supported by the Joint Commission actually do minimize harm, and then implementing them fully, not just treating them like more paperwork.
Okay, let's unpack that first and honestly longest phase, preoperative nursing, which is all in Chapter 14. We sometimes forget this phase can start weeks before surgery, maybe during pre-admission testing or PA.
Right. And the overarching goal of that whole preoperative assessment is simple. Get the patient as healthy as you possibly can before the first incision.
It's vulnerability mapping.
It's exactly that. We are systematically identifying and addressing every single risk factor that could delay recovery or, even worse, cause a major complication.
That has to start with the mandatory documents. Let's clarify the roles around informed consent and the history and physical, the H&P, because they can get confusing.
They can. So informed consent is purely the patient's decision. It has to be voluntary and documented in writing. The patient has to be legally able to consent, so 18 or an emancipated minor.
And the key distinction here is who does what.
Yes. The critical nuance is that the physician is responsible for obtaining the consent. They explain the procedure, the risks, the alternatives. The nurse's role is that of a professional staff member who witnesses the signature and confirms the patient understood what was presented.
What if a patient refuses, even after all the prep?
Refusing surgery is the patient's absolute legal right, period. Now, in an emergency, the surgeon might operate to save a life, assuming implied consent, but every attempt still has to be made to contact family for formal consent if the patient is unconscious.
And the H&P?
The history and physical is mandatory, completed by the surgeon, sometimes the anesthesia provider, and it has to be updated within 24 hours of surgery for anyone who's not already an inpatient. It must be current and accurate.
And it gives us that whole patient picture.
The whole picture. History of present illness, all the past histories, surgical, medical, social, family allergies, current meds, and the final plan of care.
Okay, let's talk about the health history deep dive. The specific system risks, starting with the physiological areas that anesthesia hits the hardest.
For respiratory status, you have to assume compromised ventilation during and after surgery. It's almost a given.
Which is why we teach deep breathing and incentive spirometry so early.
Exactly. And any acute respiratory infection, that means postponing elective surgery. A major insight the text gives is on smoking cessation. Even stopping for a short time drastically improves wound healing and reduces the risk of VTE and pneumonia.
That's especially important for patients getting implants, right?
Oh, it's vital. For knee or hip replacements where an infection can be catastrophic, it's non-negotiable.
Okay, next up is the heart. Cardiovascular status.
We need a baseline. We have to know what we're working with to manage the stress of surgery. We're assessing for comorbidities like undiagnosed congestive heart failure or arrhythmias.
So baseline vitals and ECG.
Baseline vitals are essential, and often an ECG and chest x-ray are required to catch those subtle, undiagnosed cardiac issues. If there's any evidence of cardiac decomposition, meaning the heart isn't compensating, elective surgery is off.
And what about the two major detox organs, the liver and the kidneys?
The hepatic system is critical. The liver is the biotransformation site for most anesthetic agents. Acute liver disease is associated with extremely high surgical mortality, up to 20% in some cases.
Wow.
So optimizing liver function beforehand is essential. Likewise, the renal system excretes these agents. So surgery is generally contraindicated for severe acute nephritis or renal insufficiency, unless it's life-saving or it's surgery to improve kidney function itself.
The endocrine risks are also incredibly high stakes, especially with patients who have diabetes or are on steroids.
The patient with diabetes is facing a double threat. You've got hypoglycemia during the MPO period or under anesthesia, and then severe hyperglycemia from the surgical stress response post-op.
And hyperglycemia is a huge risk for infection.
A huge risk for surgical site infection, or SSI. The goal is strict glycemic control for better outcomes. Equally crucial are patients on long-term corticosteroids. If you stop those abruptly, the patient loses their natural stress response,
which can lead to adrenal insufficiency.
And potentially fatal cardiovascular collapse. Their usage has to be explicitly flagged, and often they'll need a pre- and post-op IV steroid bolus to compensate.
This pre-op phase is also when we screen for hidden infections or sensitivities like latex.
Right. Standard labs like a WBC and urinalysis screen for any occult infection. For sensitivities, latex allergy is a major safety concern. We screen for a history of reactions, exposure risks like having had multiple surgeries, and we look for cross-sensitivities.
You mean allergies to certain foods?
Exactly. Allergies to foods like bananas, avocados, kiwi, or chestnuts can indicate a potential latex allergy.
Yeah.
Using a tool like the Latex Allergy Assessment Form is a crucial part of that preemptive risk management.
Okay, let's shift to physical optimization, nutrition and fluid status.
Optimal nutrition is just fundamental. It promotes healing, it fights infection. Poor nutrition is a common cause of delayed healing. So we assess BMI and hydration status
We follow the NPO guidelines.
meticulously. But we also have to manage the risk of overfasting. Adults fast for 8 hours for fatty food, 6 for milk, but clear liquids might be allowed up to 2 hours before an elective procedure.
But prolonged fasting or a really aggressive bowel prep can be a problem too.
It can. It can risk severe fluid and electrolyte imbalances that have to be corrected before the patient ever sees an anesthetic.
And something as simple as, well, dental hygiene can become a surgical complication.
Absolutely. Dentition is critical because decayed teeth or loose prostheses can get dislodged during intubation.
Causing aspiration.
Or they could just serve as a source of a really severe postoperative infection, especially in complex surgeries.
How do you handle the sensitive issue of drug and alcohol use?
Excessive alcohol consumption is a major red flag. It increases the risk of arrhythmias, infection, acute withdrawal, and a much longer hospital stay.
And if a patient is acutely intoxicated,
Surgery is postponed, period. The key nursing skill here is using frank, non-judgmental questioning, asking specifically about frequency and quantity. For example, have you had 2 or more drinks per day regularly in the last 2 weeks?
because denial is common?
Denial is very common, and chronic users are often malnourished, so they'll need nutritional intervention too.
And finally, what about the risks you can't see? The inherited ones, like malignant hyperthermia.
Malignant hyperthermia, or MH, is a textbook example of a genetic risk factor. It's an inherited, autosomal dominant condition.
So the nurse has to specifically ask about family history.
Yes, specifically probe the family history for things like sudden, unexplained death during athletic events or surgery. That can indicate a predisposition to this potentially fatal reaction to anesthesia.
Let's delve deeper into medication management, because this is where planning can hit some serious roadblocks, especially with things patients take every day without thinking about the danger.
The text has a vital table for this, table 14-3. It's a quick reference for high-risk meds. Take corticosteroids again. If they're stopped suddenly, the patient crashes. We have to anticipate that and give an IV bolus.
What else is on that list?
Then you have diuretics. They can cause electrolyte imbalances like hypokalemia, which can lead to excessive respiratory depression when combined with anesthetic agents. And phenothiazines can potentiate the hypotensive effects of anesthesia, creating these profound drops in blood pressure.
And then there are the bleeders, the antiplatelet and anticoagulant agents.
Right. Medications like aspirin, warfarin, or clopidogrel, which inhibit platelet aggregation. They're typically discontinued 7 to 10 days before surgery.
And the reason is pretty straightforward.
It is. They prevent clotting. If a patient bleeds excessively during surgery, their whole recovery is compromised. That cessation has to be managed very closely with the prescribing physician.
Then there are the hidden dangers, the herbal supplements that patients often forget to report because they think of them as natural or harmless.
This is a massive safety gap. You have to ask patients directly about supplements. Many common herbs carry significant risk. For example, garlic, ginkgo biloba, ginseng, and vitamin E all increase the risk of bleeding.
So they act almost like an antiplatelet agent, but the patient has no idea.
Exactly. And what about interactions with the anesthetic itself? Kava kava, St. John's wort, and valerian can profoundly prolong the sedative effects of anesthesia.
Which means a longer time to wake up, a longer PACU stay.
Right, and ephedra is a stimulant that can cause dangerous increases in blood pressure and heart rate when combined with certain anesthetic meds. That's why the American Society of Anesthesiologists just recommends stopping all herbal supplements at least 2 weeks before elective surgery.
This exhaustive risk assessment then needs to be customized for high-risk populations. Let's start with older adults.
For older adults, the hazards are really proportional to their comorbidities and the length of the procedure. The key physiological difference is reduced reserve.
What do you mean by reduced reserve?
They have lower cardiac, renal, and hepatic reserves. They're just less able to compensate for the stress of anesthesia, fluid shifts, or blood loss.
So what are the specific assessment needs for this group?
We need a hypervigilant assessment of their CV, respiratory, and renal systems. And critically, we have to assess their baseline memory and cognition.
Because of the risk for delirium.
A huge risk for acute confusion, delirium, and disorganized thought patterns during stressful states like surgery. And education needs to be multimodal verbal, written, delivered slowly, with more time to confirm they've retained it.
Okay, what about bariatric patients? They present a really unique respiratory threat when they're lying down.
They do. Bariatric patients face an increased risk of complications like SSIs and delayed wound healing. But the most immediate threat is respiratory. The increased fat limits chest expansion when they're supine, which increases the risk of hypoventilation.
And there's a high prevalence of undiagnosed sleep apnea.
A very high, often undiagnosed prevalence of obstructive sleep apnea, or OSA. That's where a specific screening tool becomes essential.
The Stop-Ya-Bang assessment.
That's how we identify the risk early. The acronym is a memory aid. Snoring, tiredness, observed apnea, high blood pressure, high BMI, age, large neck circumference, and gender.
And a positive screen changes everything.
It dramatically changes the intubation plan and the postoperative monitoring requirements. It significantly reduces the risk of respiratory collapse in the PACU.
For patients with physical or mental disabilities, the focus shifts to communication and safety.
We have to anticipate their needs. Do they need assistive devices like hearing aids or glasses as soon as they wake up? Do we need a sign interpreter, especially with everyone in masks?
And positioning.
Meticulous attention to positioning. We have to ensure their baseline functional alignment is maintained to prevent pressure injuries, which they might not be able to sense or articulate because of neuromuscular disorders.
And finally, the two extremes of scheduling. Ambulatory versus emergency surgery.
In ambulatory surgery, the time frame is just compressed. The nurse has to assess quickly, anticipate recovery needs, and start discharge planning immediately. For emergency surgery, assessment and resuscitation are often happening at the same time. The priority is calm communication and getting that essential data allergies, last meal, history from family members if the patient can't communicate.
Okay, so once the assessment identifies all the risks, the interventions shift to direct patient education and physical preparation.
Right, and the education has to be individualized and reinforced using multiple methods, verbal instruction, written handouts, and, crucially, return demonstration.
And you have to tell them what to expect physically.
You have to. Things like the dizziness from pre-medication so the unknown doesn't just compound their anxiety.
Let's focus on the physical prep for preventing post-op complications, particularly the respiratory training from Chart 14-5.
This is non-negotiable for recovery. We teach diaphragmatic breathing, practiced in a semi-Fowler position, emphasizing slow, deep inhalation. Then, controlled coughing, which is essential to clear secretions and prevent pneumonia.
And the incentive spirometer.
The incentive spirometer technique has to be demonstrated and practiced until the patient can do it correctly. It promotes maximal lung expansion and prevents atelectasis.
And promoting mobility is the other major preventative intervention.
Early and frequent ambulation is the gold standard for preventing VTE and atelectasis. We teach turning techniques using side rails and specific extremity exercises.
Like ankle circles.
Exactly. Flexion and extension of the hip and knee, ankle circles, things they can do in bed. We have them do them 5 times every hour while awake. This improves circulation and prepares their muscles for getting up.
Education also sets the stage for pain management expectations.
It does. We introduce and explain the pain intensity scales they'll be using. It's vital to differentiate between expected acute post-op pain and any pre-existing chronic pain to set realistic goals.
And you emphasize a scheduled approach.
Always. A scheduled preventive approach to pain control, rather than waiting for the pain to spike, is far more effective.
What are the final preparations right before they transfer to the OR?
Bowel preparation, like enemas or laxatives, is usually just for abdominal or pelvic surgery. The goal of skin preparation is decreasing bacteria. That involves a full body wash with antimicrobial soap the night before.
And voiding.
And finally, the patient must void immediately before going to the OR. This empties the bladder, promotes visibility for low abdominal surgeries, and prevents unnecessary catheterization or distension later.
And the timing of those last-minute medications is critical, especially antibiotics.
Yes. If a sedative pre-medication is given, the patient stays in bed, side rails up, because of the fall risk. But the most precise timing is for prophylactic antibiotics. They have to be given at a very specific time.
Usually within an hour of incision.
Exactly. Usually 30 to 60 minutes before, so that the drug's peak concentration is in the patient's tissues and bloodstream at the exact moment the incision is made. That maximally reduces the SSI risk.
We can't overlook the psychosocial interventions. High preoperative anxiety can literally hurt recovery.
It absolutely can. Fear of pain, loss of control, body image changes, these are universal. High anxiety correlates with increased post-op complications like hypertension and arrhythmias.
So what can the nurse do?
Nurses introduce cognitive coping strategies like guided imagery, distraction, or music therapy. And the nurse needs to respect cultural norms. Things like stoicism about pain, religious objections to blood products, or specific views on sacred body areas like the head. These needs are documented and communicated. So the planning phase is done. Now we move into the restricted zone, Chapter 15, the intraoperative phase. This is where precision, sterile technique, and vigilance are just paramount.
The surgical team is highly specialized. Let's break down those core roles again, starting with the two main nursing roles.
The team is composed of the patient, the anesthesiologist, or CRNA, the surgeon, the scrub role, the circulating nurse, and sometimes an RN first assistant.
Let's talk about the circulating nurse. They're the non-sterile coordinator responsible for everything outside the surgical field.
They are the eyes and ears for patient safety. They manage the environment, the equipment, the resources. Their duties include proper patient positioning, coordinating the timeout, documenting the whole procedure, managing specimens,
Fire safety, too?
fire safety, monitoring for infection control breaches, and critically, the circulating nurse leads the team debriefing after surgery to review equipment, counts, and identify issues.
And the scrub role. Their key accountability is managing the sterile instruments.
Yes, they set up the sterile field, pass instruments to the surgeon, maintain strict sterile technique. And their most critical task, which they do with the circulating nurse, is the meticulous sponge, needle, and instrument counts.
And these counts happen at specific times.
3 specific times. When the case begins, when closure of a body cavity starts, and again at skin closure. Any discrepancy means an immediate halt in intervention, which could even include an X-ray.
Okay, and the anesthesia provider is managing the patient's physical status second by second.
They select and administer the anesthetic, manage the technical delivery, and continuously monitor every single physiological parameter. Pulse, BP, ECG, O2 sat, temperature, blood gases. A key function is maintaining the patient's airway, which might involve an LMA or an endotracheal tube.
Infection control in the OR requires strict adherence to specific zones.
Right. The OR is compartmentalized for safety. You have the unrestricted zone where you can wear street clothes. The semi-restricted zone requires scrub clothes and caps.
And the restricted zone.
And the restricted zone, the area right around the patient and the sterile core, requires scrub clothes, caps, masks, and shoe covers. The ventilation is also highly controlled, with specialized ORs using things like laminar airflow units for hundreds of air exchanges per hour to minimize airborne bacteria.
Let's just quickly review the foundational principles of surgical asepsis. It's a culture of perfect compliance.
It is absolute. Key principles include only sterile objects touch sterile objects. The surgical team's gown is considered sterile only from the chest to the level of the sterile field and on the sleeves from 2 inches above the elbow to the cuff.
And you maintain a 1-foot distance.
A minimum 1-foot distance from the sterile field to prevent accidental contamination. If sterility is breached, if someone turns their back or a barrier gets wet, it has to be replaced immediately. No exceptions.
We come back now to patient safety and the verification process inside the OR itself.
This is regulatory compliance at its peak. Before any incision, the circulating nurse coordinates the timeout. Every single team member must verbally confirm the correct patient identity, the correct procedure, and that the surgical site has been marked and is visible after draping.
And no one cuts until everyone agrees.
No incision is made until all team members agree.
Beyond system errors, the patient is vulnerable to specific physical hazards while they're unconscious, particularly positioning injuries.
The nurse is the patient's guardian against physical harm. Positioning must ensure functional alignment, prevent pressure on nerves and bony prominences, and avoid obstructing vascular supply.
Like with the Trendelenburg position.
Exactly. Head is lowered to displace the intestines. You need padded shoulder braces, but the nurse has to make sure they don't cause a compression injury to the brachial plexus nerve bundle. Sustained pressure in any position can lead to nerve palsy or skin breakdown.
What about the long-term hazards faced by the OR staff?
The major ongoing professional hazard is surgical smoke, or plume, created by electrosurgical units or lasers. This plume contains toxic gases like benzene and cyanide, bioaerosols, even viruses.
And the data on that is pretty shocking.
It is. Data suggests breathing this daily is comparable to smoking up to 30 unfiltered cigarettes. Safety requires local exhaust ventilation or smoke evacuators used near the source, and staff should be wearing N95 masks. A standard surgical mask is not enough.
And the constant worry of retained items, even with meticulous counting.
Retained surgical items, or RSIs, are a failure of the safety culture. While manual counting is primary, modern ORs rely on backup technology, like radio frequency or RF chips that are embedded in sponges.
So you can scan the patient before closing?
You scan with a wand before final skin closure. It's an essential redundancy.
And fire risk is real, especially with certain preps and equipment.
Fire requires three things: an oxidizer, like oxygen, a fuel, like drapes or flammable preps, and an ignition source, like an ESU or a laser. The AORN Fire Prevention Assessment Tool helps flag high-risk situations, like surgery in the head and neck region where oxygen is concentrated.
Okay, let's discuss the core intraoperative process, anesthesia and sedation. What defines general anesthesia?
General anesthesia achieves narcosis, which is unconsciousness, analgesia, or pain loss, relaxation, and loss of reflexes. The patient is unarousable and requires ventilatory assistance to maintain their airway.
And there are 4 stages, with stage 2 being particularly dynamic.
They are. Stage 1 is the beginning, dizziness, warmth. Stage 2 is excitement or delirium. This is the high-risk moment during induction or emergence, where the patient might thrash, try to sit up, or vomit. The team has to maintain quiet and restraint during that brief, uncontrolled period.
Then stage 3 is surgical anesthesia.
Quiet, relaxed, unconscious. Stage 4 is medullary depression, a life-threatening stage that signals respiratory arrest.
What about for anesthesia agents like propofol?
For anesthesia offers advantages like smoother induction and less post-op nausea. Propofol is favored for its rapid onset and rapid awakening. Ketamine is unique. It provides profound analgesia, and the patient usually maintains their airway, but it can cause hallucinations and delirium on emergence.
So they need a specific environment in the PCU.
A quiet, darkened area to minimize that.
Okay, moving to regional anesthesia, what's the difference between spinal and epidural?
Regional anesthesia involves injecting an agent around nerve pathways. Spinal anesthesia is a single injection into the subarachnoid space, usually at L4, L5. It results in a profound sensory and motor block of the lower body. Epidural anesthesia is injected into the epidural space and usually involves a continuous catheter infusion.
What's the immediate crisis risk with an epidural?
If the dura is accidentally punctured during the attempt, the anesthetic can rapidly enter the subarachnoid space, causing what's called a high spinal anesthesia,
Which means?
catastrophic hypotension and respiratory arrest. It requires immediate ventilatory support.
And the use of peripheral nerve blocks, or PNBs, seems to be a key part of modern pain control.
It is. PNBs involve injecting anesthetic, opioid, or steroid directly into a nerve bundle, often guided by ultrasound. Best practice now is placing PNDs in the preoperative area.
Why there?
Because it allows the block to be fully effective the moment the patient emerges from general anesthesia. So they wake up with less pain, need significantly less opioid, and spend less time in the PTU.
Let's talk about the intraoperative crises that demand immediate protocol-driven intervention, starting with malignant hyperthermia.
Malignant hyperthermia, MH, is a clinical emergency. It's rare, maybe 1 in 20,000 cases, but it is a life-threatening inherited disorder triggered by anesthetic agents like succinylcholine and volatile gases.
And what's the mechanism of this crisis? How does it actually manifest?
Pathophysiologically, it's an uncontrolled increase in skeletal muscle oxidative metabolism. It's caused by an atypical release of calcium within the muscle cells. The body essentially overheats from the inside out.
And the first sign is often tachycardia.
Right. Tachycardia over 150 beats per minute is frequently the very first sign. Then comes hypercapnia, increased CO2, and rigidity, often starting with the jaw. That rapidly rising temperature up to 1 to 2 degrees Celsius every 5 minutes is actually a late sign.
A late sign, wow.
And core temps can get over 42 degrees Celsius, which is about 107 Fahrenheit.
What's the life-saving intervention?
Immediate cessation of the trigger agent, aggressive cooling, reversing the acidosis, and the administration of dantrolene. Every OR has to have an MH cart with the drug and clear protocols from MHAUS, the Malignant Hyperthermia Association of the United States.
What about the psychological crisis of anesthesia awareness?
This is unintended cognizance under general anesthesia. The patient may not feel pain, but they often sense pressure or hear conversations.
And if they're paralyzed by neuromuscular blockers?
They're unable to move or communicate their distress, which can lead to profound post-traumatic stress. The OR nurse is key in recognizing subtle physical cues and supporting the patient psychologically afterward.
Respiratory function is non-negotiable. What signs signal impending hypoxia?
Inadequate ventilation from an airway obstruction, often just the tongue relaxing back against the pharynx, causes hypoxemia very rapidly. The signs are decreased O2 saturation, visible chest effort without air movement, or subtle changes in skin color.
So monitoring is key.
Vigilant monitoring with pulse oximetry and capnography, which measures end-tidal CO2, is essential. Brain damage can occur in just minutes.
The OR environment itself can induce risk, specifically with temperature regulation.
Unintended hypothermia, a core temp below 36.6 Celsius, is a major complication risk. It increases the risk of CV events, impairs clotting, so it increases bleeding, delays arousal, and it doubles the risk of SSI.
Why does it increase infection risks?
Because vasoconstriction reduces oxygen delivery to the surgical site, which is needed for healing. Nursing management includes warming IV and irrigating fluids, using warm air blankets, and keeping the OR between 20 and 24 degrees Celsius.
Finally, we need to address two serious pharmacological complications: anaphylaxis and local anesthetic systemic toxicity, or LAST.
Anaphylaxis is a severe systemic allergic reaction, maybe from latex or a medication. Intervention has to be prompt within 3 minutes to prevent circulatory and respiratory collapse. LAST is rare but demands immediate recognition. It happens when a local anesthetic gets into the systemic circulation too quickly.
What are the warning signs of LAST? Why is that early recognition so critical?
The early symptoms are often subtle. A metallic taste in the mouth, oral numbness, auditory changes, lightheadedness. Those are the immediate warning signs before the patient progresses rapidly to seizures, severe arrhythmias, and respiratory arrest.
And the treatment.
Management focuses on airway protection with 100% O2 and the specific administration of 5E lipid emulsions, which effectively bind the anesthetic and reverse the cardiac and CNS effects.
We transition now to Chapter 16, the postoperative phase. The surgery is technically complete, but the most intense period of physical recovery is just beginning in the PCU.
Right. This is a phase defined by intensive minute-to-minute vigilance. The patient is transferred slowly and deliberately from the OR table to the PCU stretcher to minimize the risk of orthostatic hypotension and protect the surgical site.
And the quality of that handoff is paramount. What information is in that critical report from Chart 16-1 that the PCU nurse has to receive?
The PCU nurse gets a comprehensive report from both the anesthesia provider and the circulating nurse. It covers patient history, the procedure performed, incision type, all anesthetic and reversal agents used, estimated blood loss, fluid intake, urine output, and any complications.
And the anesthesia provider stays?
Typically, yes. They remain until the PCU nurse confirms the patient's airway is patent and initial stability is achieved. And we have to note special requirements. If the patient had ketamine, they need that quiet, darkened area.
What are the immediate assessment priorities, and how often are vitals checked?
The priorities are always hierarchical: airway, level of consciousness, cardiac, respiratory, wound, and pain. Vital signs are typically assessed every 5 to 15 minutes, depending on the protocol, to identify any downward trend very rapidly.
Okay, let's elaborate on the single most important objective: maintaining a patent airway.
The major threat is hypopharyngeal obstruction, where the tongue relaxes and occludes the airway. The signs are snoring, choking, labored breathing, or a rapidly decreasing O2 sat.
And the immediate intervention.
The immediate life-saving intervention is the jaw thrust or head tilt chin lift maneuver to pull the tongue forward. Any oral airway device has to stay in place until the patient's protective reflexes, like the gag reflex, fully return.
And if they start to vomit?
They must be immediately turned onto their side to prevent a fatal aspiration.
Once the airway is secure, the focus shifts to cardiovascular stability.
We constantly monitor LOC and vital signs. The alarm bell is hypotension. A systolic BP below 90 or a downward trend of 5 mmHg over consecutive 15-minute readings demands immediate attention.
And the most common form of shock post-op is hypovolemic,
usually due to hemorrhage at the surgical site or internal bleeding.
What are the classic urgent signs of hypovolemic shock that the PCU nurse is looking for?
Pallor or extreme paleness, cool, moist, clammy skin, a rapid, weak, thready pulse, a narrowing pulse pressure where the difference between systolic and diastolic gets smaller, low blood pressure, and increasingly concentrated urine.
And the primary treatment is volume.
Aggressive volume replacement, starting immediately with crystalloid solutions like lactated ringer or saline, and preparing for potential blood transfusions.
Hemorrhage can be sneaky, though. It's classified by when it occurs.
Right. It's not always immediate. Primary hemorrhage is at the time of surgery. Intermediary hemorrhage is in the first few hours as the patient's blood pressure normalizes and dislodges clots. And secondary hemorrhage can happen days later from a slipped suture or an infection eroding a blood vessel.
And you have to know what kind of bleeding it is.
If the bleeding is arterial, it will be bright red and spurting. The critical nursing intervention for visible external bleeding is immediate. Apply a sterile pressure dressing, elevate the site, and place the patient in the shock position flat on their back with legs elevated about 20 degrees.
Once the patient is stable, their comfort becomes key, especially managing postoperative nausea and vomiting, or PONV.
PONV is incredibly common, and it carries significant risk: aspiration, dehydration, and increased tension on suture lines, which can lead to dehiscence.
And the risk factors are pretty clear.
Very clear. Female gender, age under 50, a history of motion sickness, and reliance on opioids. Management involves multimodal anemetics, often given prophylactically, and non-pharmacologic methods like ginger or peppermint aromatherapy.
Effective pain management is crucial, not just for comfort, but for preventing other complications.
It is. We use a preventive, scheduled approach over a reactive PRN approach, often starting with the IV route for rapid onset.
And the most vital nursing intervention for opioid safety.
Using a validated sedation scale before every single dose. The POSS, the Passero Opioid-Induced Sedation Scale, assesses the level of consciousness. The critical rule is typically withholding the opioid if the patient reaches a sedation level of 3 or higher, meaning they are difficult to arouse. This prevents respiratory depression.
This feeds directly into the modern strategy of multimodal analgesia, often used in ERA's pathways.
Correct. Multimodal analgesia involves combining non-opioid agents like NSAIDs and acetaminophen with local anesthetics and regional nerve blocks. This strategy drastically reduces the total opioid dose required.
Which minimizes side effects.
Right. Less sedation, less respiratory depression, less constipation, which all accelerates recovery. Patient-controlled analgesia, or PCA, fits here too. It allows the patient to self-dose within set limits, which empowers them to move and cough with less pain.
The ultimate goal of the PCU is objective readiness for transfer. How is that determined?
That's done using the Aldrete score, from figure 16 to 3. It's an objective tool that scores 5 criteria from 0 to 2: activity, respiration, circulation, consciousness, and O2 saturation. A score of 7 to 10 is usually required for a safe transfer.
Once they're on the surgical unit, the focus shifts a bit from crisis avoidance to progression toward healing. What are the immediate interventions upon arrival?
The receiving nurse assesses breathing, monitors vitals frequently, checks the surgical site and drains, assesses consciousness and pain, and immediately reinforces the need for deep breathing and leg exercises. The goal is rapid activity promotion.
And why is early ambulation so heavily emphasized at this stage?
Early ambulation is the single best intervention to prevent atelectasis, pneumonia, and VTE. Safe ambulation requires careful, gradual position changes, sitting up, dangling the legs, while checking for orthostatic hypotension.
Okay, let's discuss wound healing, the central focus of late postoperative care. The text defines 3 specific phases.
Right, from chart 16 to 5. The inflammatory phase starts immediately with clot formation. Neutrophils and macrophages move in to clean up debris. It's marked by redness, heat, and swelling.
Then the proliferative phase.
The proliferative phase is where fibroblasts synthesize collagen, new blood vessels form, and epithelialization occurs. Clinically, we're looking for that beefy red, healthy granulation tissue.
And the final phase is remodeling.
The remodeling phase begins around 3 weeks and can continue for months. The fibrous scar develops, shrinks, and increases its tensile strength. The healing mechanism also defines the intention of the closure. First intention is a clean, sutured incision. Second intention is when the edges aren't approximated and the wound heals naturally by forming extensive granulation tissue, like with a large burn.
And we have to assess for factors that can alter or delay this healing process.
Many factors are manageable by the nurse. These include things like age, hemorrhage, edema, and nutritional deficits, especially protein. Systemic factors like uncontrolled diabetes, smoking, and medications like corticosteroids can severely impair the healing response.
What happens when the healing fails, leading to the dramatic complications of dehiscence and evisceration?
Dehiscence is the partial or complete separation of the wound edges. The patient might describe a popping sensation or a sudden gush of serosanguineous fluid. Evisceration is the protrusion of organs through the incision.
And what is the critical nursing alert action for either of those?
Immediate action is required. Place the patient in the low Fowler position with the head of the bed slightly raised and knees slightly bent. Instruct them to lie as still as possible to minimize tension and cover the wound with sterile gauze moistened with sterile saline. This prevents tissue drying while awaiting the surgeon.
Wound management also involves drains.
Yes. Drains like the Penrose, Jackson Pratt, and Hemovac are placed to prevent fluid accumulation, which is just a perfect culture medium for bacteria. Closed suction systems, like the JP drain, use gentle, constant negative pressure to actively pull fluid out.
And the nurse's job is to monitor that output.
Monitor the output, the color, and make sure the suction is maintained.
Finally, we have to confirm the resumption of elimination function, both bowel and voiding.
Bowel function slows way down because of anesthesia, opioids, and immobility. This leads to a high risk of constipation or even a paralytic ileus. We assess for bowel sounds and flatus. Early ambulation is key here.
And voiding the text gives a very specific time frame for concern.
Patients are expected to void within 8 hours post-surgery. Anesthetics and opioids interfere with the patient's perception of bladder fullness.
So what can you do?
Strategies to encourage voiding include using a warm bedpan or allowing the patient to stand or sit. If the patient hasn't voided, you have to use a bladder scanner. Straight intermittent catheterization is strongly preferred over an indwelling catheter to reduce the risk of a UTI.
The journey culminates in home care and discharge education.
Right, and discharge education from chart 16 to 3 is critical, especially for ambulatory patients. Written instructions must be provided to both the patient and the caregiver.
And it has to cover everything.
Everything. Activity limits, no driving or alcohol for 24 to 48 hours, detailed wound care, including signs of infection like redness or drainage, pain management instructions, and clear follow-up contact info. The nurse has to ensure a safe transition to home. This deep dive really reinforces that perioperative nursing is a fluid continuum. The precision of that preoperative assessment, identifying medication risks, genetic predispositions like MH, and chronic conditions like OSA, that is what actively prevents intra- and postoperative crises.
It proves that risk mitigation in Phase 1 directly dictates safety in Phases 2 and 3.
Exactly.
So the major takeaways stand out pretty clearly. First, the cornerstone of safety is the regulatory framework. Unwavering adherence to the surgical safety checklist, especially that critical timeout, coupled with the meticulous principles of surgical asepsis.
Absolutely. And second, the nurse's role as the patient advocate in the high-stress OR environment is paramount. You're protecting the unconscious patient from positioning injury, from hazards like surgical plume, and you're monitoring for those rapid onset crises like MH or LAST.
And thirdly, in that immediate postoperative phase, the focus is pure physiological stabilization. Immediate airway management and prompt recognition of impending hypovolemic shock take precedence over everything else.
Followed closely by effective multimodal pain control, guided by objective measures like the POSS scale to prevent respiratory depression.
We've meticulously tracked how the nurse uses planning, monitoring, and communication to shepherd a patient through this incredibly complex journey. So for you, the crucial question that builds on this unit is this.
As surgical care moves more toward rapid recovery models, or ERAs, that prioritize early mobility and reduced opioid use, how do we advance our nursing assessment to detect the subtle, non-physiologic complications? Things like toxicity from advanced nerve blocks or the psychological distress of anesthesia awareness that might delay or derail that goal of rapid recovery.
That's a compelling charge for future practice. Thank you for joining us for this deep dive into perioperative nursing management. We hope this knowledge supports your critical thinking and respects your time.